Anyone wishing to testify, please make sure and sign up right there next to the podium. Thank you.
thank you very much. We will call the meeting of Health and Human Services to order. And I promised Representative Benefiel, since she may be called away to Judiciary, that we would hear her bill first. That's her resolution. That's House Resolution 1341.
Which is asking for a study committee to look into the practice of midwifery in Georgia. And specifically, we're looking at certified professional midwives to perform births in out-of-hospital settings or home births. Many of you probably know this, but in Georgia, many women are having out-of-hospital births. It's currently a gray area of the law, and these women who are practicing midwifery aren't legal or illegal. And I'll go into a little more detail in the as to what the statutes and the regs say in just a little while. But they are practicing in Georgia, and they are having, women are choosing this as an option. And so what I'm asking is that we as a legislature be responsible and recognize that this is a reality, that many women are choosing home births. And for those women who are opting to have a birth at home, and with a professional midwife, that we provide some structure to make sure that this is done as safely for the mother and for the children and for society. Let me just talk a little bit about some of the categories of midwives. There's a certified professional midwife. That's recognized in some 29 states, and every state has a slightly different way of how they regulate and structure the practice of midwifery. But many of them, and most of them, do choose to follow the regs adopted by NARM, the North American Registry of Midwives. And basically, they have several components to being certified under NARM, and that includes an educational component where you have to go to an accredited midwifery school, also pass a written examination, and then there's a clinical component that includes supervising 20 births in a hospital, 20 births actively under supervision, 20 births where you are the primary midwife but still supervised, and then 10 of those births have to be in a home setting. And it also has extensive examination requirements. You have to have 75 prenatal exams, and I can't remember the exact number. I think it's 20 postpartum exams, but there's a strict clinical component to that as well, in order to be recognized as a certified professional midwife. And every state has slightly different standards, but they do look at the NARM as sort of setting the bar. Then there's also certified nurse midwives, and those are midwives who have to have a nursing degree. You may be familiar with them. I think you've heard a lot about prescriptive authority today. The nurse midwives were included in that. And they are recognized in Georgia. And we do have certified nurse midwives practicing in Georgia in a hospital setting, mostly under the supervision of an OBGYN practice. The CPMs, the certified professional midwives, like I said, are recognized in many states. The southern states, for your information, are South Carolina, Tennessee, Florida, Texas, and Louisiana. So a lot of our neighbors are doing this. I'll go over briefly some of the history of midwifery in Georgia. There's actually a code section in our statutes. It's in Title 31 that allows for midwives in Georgia to practice in midwives, and it defines midwife as a person who practice not licensed under the laws of the state to practice obstetrics, who is regularly engaged in attending women in childbirth. Does not mandate or require that midwife have a nursing degree. So that's our current law actually defines midwife as not having a nursing degree. And the law also goes on, and I won't read it all, but I'm happy to provide the committee with a copy of it, but it does charge the Department of Public Health with setting rules and regulations to regulate the practice of midwifery. And the Department of Public Health's regulations are the ones that mandate that midwives have a nursing degree. So there's actually a glitch right now in the regulations. We've got a state statute that says one thing, and then the regs that say another. So it really is a gray area of the law, and it needs to be clarified. And that's what I'm hoping that we will do is have a study committee. And I'm not saying that I have the absolute best response on how to resolve these problems. I think we need to bring experts together, bring OBGYNs, bring certified professional midwives, get a nurse midwife, but get people who are involved in this issue together, and let's come up with a solution on how to regulate this practice to make sure that it's safe. I will say that there are numerous statistics that show that a low-risk pregnancy, women have just as healthy a birth at home as they would in the hospital, and I'm talking about low-risk pregnancies. And there are less C-section rates, there are less interventions. It's a much healthier experience for a home birth if you are a low-risk pregnancy, and certainly dramatically reduced cost. A home birth costs about $1,500. And hospital births, I think, run, well, I can tell you from my own experience, if you get a C-section, it's anywhere from $10,000 to $20,000, because I just had a C-section. So there's a lot of benefits to looking at these out-of-hospital births. And I'm just simply asking that we have a study committee and we pursue this issue further. Like I said, this is a choice. My own personal experience, I chose to have a doctor and to be in a hospital because I was a high-risk pregnancy. I'm just turned 40, so because of my age, I was higher risk, and that was the best choice and decision for me and my family. And I just respect that women have different choices based on their assessment with their medical health professionals, and I would ask the committee to seriously consider allowing us to pursue this issue further. This issue will be around. Whether we decide to act on it this year or not, women are going to continue to have home births, and I think the responsible thing is for us to study it and to act in a way that will be in the best interest of the women and children of the state. And I'll ask Abel Nabel to add her comments. And I'm happy to answer questions afterwards.
There we go, Ryan.
She's also one of the co-sponsors of the bill, and just talking about the bill. I thank you for the opportunity to come, members of the committee, and I really won't be long. I basically had the opportunity to attend a conference recently with the Association of African American Midwives, and at that conference, the topic that they dealt with was midwives and reducing infant mortality. And so what we're trying to do too with the study committee is to see if there's any opportunity, whether or not there's a correlation between really re-entering or really placing the whole issue of midwifery and maternal care back into the formula, and whether or not it could help reduce infant mortality throughout the state of Georgia. If you look at our statistics on infant mortality, we're about 7th in the nation in terms of our high rates. And then what we did is the document that you see that I put on your pass to you just talks about the different 159 counties and the type of numbers that we have in infant mortality throughout the state of Georgia. And what we see is that the midwifery is called the Midwives Model of Care. And this is the North American Midwives Registry, and it says the Midwives Model of Care is based on the fact that pregnancy and birth are normal life processes. The Midwives Model of Care includes monitoring the physical, psychological, and social well-being of the mother throughout the childbirth and bearing cycle. As you know, if you go to the hospital now, just because everything is moving so fast, a lot of times you don't really get a chance to spend as much time with your doctor as you would like. A lot of times you do get a chance to have the doctor stick his head in the door and make sure you're okay, but a lot of this work is being done, in some cases, by the nurses. And what the midwife does is they have a complete program where they actually deal with the whole being and looking at the whole family situation. And so they do spend a little bit more time, I believe, with the mother and the father and the other members of the family. And it says also the midwife model of care is provided for mother with individualized education, counseling, prenatal care, continuous hand-on assistance during labor and delivery, and postpartum support. Also, they deal with the ones that I know, and I do know a little bit about this particular area, from the fact that in my particular area, in District 55, it's an area in Atlanta called West End. And in this particular area, during at least the 90s, there was just a large group of families in that area that chose to have home births. And they actually had safe home births. And basically, they passed the word on to their friends. And basically, there are more than 300 midwives we know that are in Georgia. And we know this practice is going on. And we do think that for some people, this is a choice that they should be able to make. And it should be a choice that is supervised and one level of, what I would say is a level of competency. So what it is that when you see the law, and the law says that you don't have to be a nurse to do it, and then the code say you do, you see that there is some discrepancy in the code as well as the statute versus the regulations. So we think that this study committee is just a beginning step for us to begin to bring clarity to this and to make sure that everybody is families are safe, but also women have the choice to have their home births and have them in a safe manner. So that's basically the contention, and we have had a chance to talk to. We did talk to Commissioner B.J. Walker, and we talked to her at a policy briefing about the whole problem around infant mortality, and she was saying that if that, anything that we can do around that area, it will be helpful. Then we also got a chance to meet this Monday with the Commissioner of Public Health, and he was really not unaware with the conflict in the code, and we do know that he did not express just opposition to it, and he wanted to see how we could proceed on this particular bill. So we have tried to talk to different people. We also had a chance to talk to some of the people who are OB-GYNs, and obviously they do have some concerns. But what we're saying is with this study committee, we put in place to say it would be 3 representatives and 2 lay people. Even though we said lay people, I basically let them know that even though we use the term lay people, we use that term in saying it wouldn't be another legislator, and we are open to having opposing views on the study committee, and we just would like to be able to work together with the people who want to make sure that births and that families are safe, and we just think that this is another alternative that women should be able to have. And to be honest with you, whether we regulate it or not, some way or another, it always has existed, and we know that it will. Thank you very much.
Thank you very much. Do members of the committee have questions for Representative Thomas or for Representative Benefield? Pardon? No. Okay, no questions. I know that we have some people that would like to speak on this issue. Please, when you come up to speak, identify yourself. Come to the mic. First person, Dr. Hatchett. So identify yourself and give us since you are a medical doctor, tell us that you are a physician and where you're from.
Yeah, I'm Dr. Thomas Hatchett. I'm a medical doctor in Georgia. I'm the president of the Georgia OB-GYN Society, and I'd like to thank the members of the committee for letting us come and talk today. We obviously have some grave concerns about this practice. There are certified nurse midwives in our state that practice. They have a nursing degree. They have at least 2 years of experience and training after that. They're recognized by the state as people who are qualified to perform this service for our patients. We feel that just because there's a glitch in the statute that we shouldn't promote people with less training and less experience to deliver babies. I don't have any problem with people having that choice to do that, but I don't think the state and the government should promote that. We've heard some talk about infant mortality today. I'm also concerned with maternal mortality. 100 years, nobody wants to have a C-section. I don't know of any woman who would prefer to have a C-section. 100 years ago, C-sections were very dangerous. Many women died from that. The maternal mortality rate dropped substantially at the turn of the century, between 1900 and 1920. And the primary reason for that was that there were more hospitals built in our country, and more women were having their babies in hospitals, and that's why fewer women died in childbirth. Just a statistician could say, if you look at the more women that are going to deliver in a home, the more problems you're going to have. Granted, most of the time you're going to be fine, but if you're going to have a shoulder dystocia or a baby gets stuck, or if you're going to have a terrible hemorrhage after delivery, or if your baby needs to be delivered quickly, those are going to best be handled in a hospital. So I don't think that we should encourage the increase of deliveries at home. So I appreciate your listening to this and just wanted to voice our concerns.
Thank
I'd be
you.
happy to answer any questions if you
Are
have.
there any questions for Dr. Hedges? Okay, thank you very much. Next on the list. Dr. Gallup?
Hey, I'm Dr. Pam Gallup from Savannah, Georgia. I'm an OBGYN in Savannah. Sorry, I'm a little nervous. Thank you for letting me speak. I would like to I could talk for 20 minutes on every sentence on this piece of paper. The biggest statement I can say is 100 years ago, the number one cause of maternal death was childbirth. And we don't have enough doctors in the state. We got tort reform passed last year, thank you so much, but it takes a while to draw these doctors back in. I've been practicing for 17 years. I can tell you that a low-risk patient can become a high-risk patient in 1 second. I hope that none of you ever see an obstetrical hemorrhage. I pray you never do. But if you did, we wouldn't even be considering this issue. 3 weeks ago, I had the worst shoulder dystocia of my career. The baby's head came out. It took me 2.5 minutes to get the baby out. The baby did fine. The mother did fine. It took me 3.5 hours to repair the damage. I am 40 minutes away from the only freestanding birthing center in the state. I didn't know it was the only one until today. And I have been the recipient of patients who are helivaced from this site to our hospital and dealt with the hemorrhages and 40 units of blood. That is an actual case, 40 units of blood. And involved a patient who was pushing for 6 hours. That is unheard of. It is unethical. But it happened. Can we guarantee that these kind of things won't happen? I understand that they probably think it'll happen and just give her another hour and another hour and another hour. And then we have an absolute emergency and something that never should happen. We have my patients who come in and say they don't want any intervention, they don't want to be monitored, they want to deliver naturally. That's fine with me. That's fine with most of the doctors I work with. A lot of us just want the little Heplock, so if there is a hemorrhage, we can put something in real quick and get some blood and fluid in if we have to. But we don't have to do that. If they come to me and say, I just want you there in case, that's fine. The chance they actually will need me, I agree with them. The chance you'll need an obstetrician there, 5%, 2%, I tell them that the first prenatal visit. The chance you'll need me there is very low because most people will do fine. But what you're paying me for is the fact that, and I have done it, I can get your baby out in my street clothes with no glove on in 11 seconds. And I've done that. I have thrown somebody on a table and had a baby out in 11 seconds. That's what you're paying me for. You're paying me for that chance. And all of you are probably parents. I'm a parent. The thought that I might have put my baby in danger, you can't go back. You just can't go back and say, gosh, I wish I'd have just been in a hospital and done this. These women have a choice. They absolutely have a choice. It's like wearing a seatbelt. You can go down 285 and you don't have to wear a seatbelt. Well, you're supposed to, but you don't have to. I'm not their mother. They absolutely can deliver at home, but legitimizing somebody delivering their baby with no care, with no medical training, and nothing available to do it, to get that 40 units of blood, to get that baby out, because I have a knife available, and I have an anesthesiologist available. When you legitimize this, you're giving these women a false sense of security. The state says it's okay, so they must be okay to do this. My fear is that if you do legitimize this, somebody with no training and nothing available, this center is fairly close to Savannah. You could never drive there in time. You can't drive through downtown Savannah and get all the way to Rankin, or from Rankin all the way through Savannah to Memorial and expect the baby to be alive. They're helivacked in. Most of them are helivacked in. And I've taken care of plenty of emergencies from this place. And we all know when it's coming. We hear it overhead. They call the obstetrician on call, and, we got a case from Lincoln Birthing Center, and we're ready. The blood bank's notified. We know we're ready. And most of the time, it's not so terrible. But there are those cases that are. One baby, just one baby. I mean, what is it worth? It's just legitimizing this just says that the state says this is okay. I don't think there's an obstetrician in this state who would say women don't have a choice to do this. They absolutely have the choice. They have the choice. That's not the issue. The issue is legitimizing this so that we say, yeah, this is a viable thing to do. We don't even legitimize not wearing a seatbelt. But you're going to legitimize a baby being born without any type of emergency equipment? We have a lot of different ethnic women here, Middle Eastern women. If they want women OBGYNs, they're available. The nurse midwives who are certified, we're right there. We are in the hospital. We are right there if they need us. I know I'm talking too much. I
It's all
appreciate
right.
your
Dr.
time.
Gallup, we have some questions. If you don't mind, will you take them? Would you be willing to take questions?
Oh, sure. I'm sorry.
Okay. Rep. Cindy Carter?
Thank you, Madam Chairperson, and thank you, Dr. Gallup, for being here today. I know you made the trip from Savannah, and as a practicing pharmacist in the Savannah area, I can attest to members of this committee of the great work that Dr. Gallup and her colleagues have done, and we appreciate that very much. And Dr. Gallup, as you know, the birthing center that you speak of, I hope you know, is in my district, so I have a big interest in this, a large interest. One thing I want to make sure that I understand, this is a resolution to set up a study committee to study this issue.
Right.
So I just want to make sure everyone understands that what will happen will be that there will be senators and representatives who will study the issue and report back to the legislature. Just wanted to make sure.
Oh, I understand.
Okay.
Representative Dotson?
Dr. Gallup, thanks, and that's me right here. And I know you were nervous, but we've met before. I think I came to Savannah about 4 years ago and spoke to the society, and you were there that night. And if I was delivering babies, I'd be nervous, so I don't feel bad. Other than the 2% to maybe 5% you said possibly of having a problem that needed a OBGYN doctor there, what are the reasons? Is there any sterilization problems that we might be looking at, or anything else that you could think of that would be a problem for the birth being outside the hospital?
Neonatal care. We have phenomenal neonatal care available. And you have a baby in trouble that could need to be intubated, put on a ventilator quickly. One of the biggest problems that babies get into is group B strep. It's a bacteria overwhelming infection that can happen very quickly. If you've seen a baby who gets neonatal group B strep, within 30 minutes they can go being from pink to blue. Just having a neonatologist, a pediatrician's available if there is a immediate problem with the baby, they need to put on a ventilator, needs antibiotics quickly. We can treat all these things. In our hospital, it's routine for 34-week babies, 6 weeks from their due date to go home with the mother. But that's because we have, phenomenal care. And these babies are helivacked all over the state. We get from Savannah, we get all these from the lower portion. Macon has it, and then Atlanta has it. These babies are helivacked everywhere, and we always are in communication. We know when babies are in trouble out there. I happen to be in a level 3 center, but we know when there's a baby born in Sylvania or Dublin or something, and they're looking for a neonatal unit. every obstetrician in that place is aware, and if we're full, we're helping call Atlanta, and we're helping call Augusta and Macon, and even Jacksonville. Do you have a place open? We have a baby. We have a baby needs help right now. But it's same as a mother. You have a low-risk patient. I wish I could tell you 100 stories of somebody low-risk that became high-risk just like that. But the babies can be like that too. But if you have somebody there for the baby and you can get the care, we can get them someplace so fast you can't even imagine how fast this Halifax system in Georgia is. It's good. It's good.
Could I, Madam Chairman, just one more quick thing. You mentioned pediatrician being there, and that would be a key also. Is that not true in a hospital? The pediatrician would be there.
Yes, sir.
And our hospital is a level 3 neonatal, I think, also. It's a great operation, but the pediatrician would also be a key. Jaundice, is that type thing prevalent? I know it's in a lot of
Yeah,
kids
there's a
today.
lot of things that develop over time, and they would have time. I mean, I would be lying if I said the babies had to have care right that second all the time. But a lot of them do.
Thank you.
Representative Mitchell.
Dr. Gallup, I feel your passion, and I tell you, I have a wife who would have appreciated 11-second delivery. But I think that perhaps your passion might be somewhat misplaced here, because all we're talking about is studying the issue at this point. And I think, was mentioned earlier, I think perhaps studying, I've been around here long enough, whereas I can tell you there have been sometimes we've suggested an issue be studied, and that was perhaps a fancier euphemism of letting it die for all practical purposes. So if it is the will of this body to do something like this, I think your passion would be better used at that time. But we're a long way from that. I think right now.
I understand. It's, I assume that there's 14,000, I guess, in the state, doctors. I don't know how many OB-GYNs, but
Yeah.
they would all come up here if they could, I know, to stop even the study. Because
Yeah.
it's 100 years ago, it was the #1 form of death in women.
Yeah.
I mean, it's been studied because we have observational studies that when women delivered at home and we didn't have hospitals, they died.
Yeah. However, and I'm sure you will agree that perhaps out of a study may come some other issues that we could take up that you might be very pleased with.
I will give you that.
Thank you, Representative Mitchell. Representative Loudermilk.
Thank you, Mr. Chair, and thank you, Doctor, for being here. Not being in the medical field, I've got some questions regarding several aspects of this, but one, are you familiar with the American Public Health Association? If so, could you explain maybe a little bit about who they are? I know it's referenced in this bill here.
I mean, I know the public health department, but I don't know.
Okay. Maybe at some point if someone could explain who that is.
Representative
I can give you their position statement. They do have a position statement on certified professional midwives, and I can give that to you, and it's on the web too. It's mentioned it. I found it last night very easily, and I can send out those statements to you. They have a statement in support of certified professional midwives, but it has not been fully adopted yet by the Board of Governors.
Okay. What is the organization? I mean, in a synopsis.
My understanding, I'm not sure, but I think it's all public health. Like we have a division of public health here in Georgia under the Department of Community Health. Dr. Switzer and everyone involved in the public health practice is invited to join us.
Okay, thank you.
I'll get you the website.
Okay.
Thank you. Representative Kidd.
Thank you so much for coming. I've been assisted by two neonatologists in the two births that I had, so I certainly have experience and know how valuable your expertise is. And I'm interested in if you have ever worked with, how you feel about certified midwives, and have you worked with them? How does that work, and is that a preferable relationship? Is that something we may discover in a study committee?
It's wonderful. The patients love it. We are there in the hospital. They're working. We don't even walk in the room, but we're right there.
So they're
All they
always,
have to do is
it's
walk
always
out
in
the
a hospital, but not a home birth?
They're right there, and the patients love it. It's a wonderful service. My practice doesn't have one. I'm on the faculty there, and I stay in-house 24 hours when I'm on call, and just for my own patients, my partner's patients, the residents who we teach, their patients, and any emergency that walks in for a patient that's not assigned. So, but there's other practices that have the nurse with midwives in their practice. Those doctors are there. They're just sleeping in the car, but they're in the hospital when she's
Delivering.
practicing. And if they weren't there for some reason, you have the faculty there 24 hours a day. Now, I can't say that all the doctors who have nurse midwives stay in the hospital. I don't know that. That's how it's done in Savannah. And at both hospitals, the doctor has to be available. But all they have to do is yell.
I was just going to ask about the prenatal aspect of it. Is what usually is the practice of a midwife?
They are in the
certified
office with the doctors and seeing their own patients. We have a nurse practitioner who, she has her own following. She doesn't deliver them, but she does all their prenatal care, and we review the chart every time she sees them. She puts them on our desk, and we go through and make sure nothing was missed and that everything's okay.
Okay, having a certification process and maybe a requirement, maybe a licensure situation would be preferable than not having some kind of structure to this practice. Can you see? Would that be helpful? Could that possibly be a positive type of development?
My concern that I want you to know from the beginning is that if I'm somebody who decides to have a home birth and I get a certified person from the state, if I don't know about how medicine works, it's already legitimized in my mind that this is okay. And she has the knowledge and the backup, or there's some process in place to help me. There's not. There's not. A home birth is just that. It's a home birth. It's the same thing that happened 100 years ago. It doesn't matter that we have a telephone, you can call 911. But it's the same thing. We have this, it's been studied. We have observational studies and statistics from the 1800s and early 1900s that when people have a lot of home births and no medical care available, they die.
Thank you.
Thanks.
We have one more. We need to sort of keep it to the thing. Thank you very much, Dr. Gallup. I certainly wish that all the women in Georgia could have you as their physician. Now that we've passed tort reform, if we can get more OBs, I'd like for you to help with recruiting. We have one more speaker on this issue that's signed up, Paul Bingnos. Sorry. You'll pronounce it correctly for me?
People pronounce it a lot of different ways. I pronounce it Paul Vigneault. I'm a father of 4 and a grandfather of 1. I'm from Pike County. Chairman Cooper, Ms. Mabel, Ms. Stephanie, members of the committee, y'all could do a wonderful thing by passing on this resolution to have a study committee to get this thing, this wonderful thing of childbirth out into the open. My grandson was born at home, and it was a miraculous, wonderful, truly great experience for myself. I was a little bit nervous, Representative Dodson, while this birth was going on, let alone to be a part of it. But it really worked out well, and it was not an option for me or for my wife when our children were born some 25, 30 years ago. But there has been evidently a resurgence of the skills and the experience amongst trained midwives in Georgia, and I would just love to see this committee go forward and allow this study committee to be formed to see if we can bring together both the midwives and the OBGYNs and everybody in the community to bring back midwifery into maternity care. And that's really all I want to say. Thank you.
Thank you very much for coming. Is there any questions? All right, any other questions for the committee? To the authors, pardon. Certainly. With respect to a fellow representative.
I will be very brief. I want to thank the committee's patience on this issue. I just want to address a few issues raised. First of all, let me say I have tremendous respect for the obstetricians in the state and appreciate all the good work they do. I do think it's an unfair comparison to look at what happened 100 years ago, and certainly many women died in childbirth 100 years ago, but that can't be attributed just to home births. And a lot of things have changed since then, not just with the hospital births, but also we've had tremendous prenatal care, and there's a lot of reasons why women rarely die in childbirth today. And the midwives that do practice in other states have extensive training. There was some talk about a glitch in the statute, or we don't want to legitimize this practice. Well, it's already in the statute, so it is something that needs to be addressed. It's more than a glitch. It's a legislative intent that this body passed some 15 years ago, saying that midwives did not have to have a nursing degree in order to practice. Complications certainly do occur in birth. I'd say that if we were to form a study committee, we would need to look very carefully at the other states and how they have dealt with that issue. We've got almost 30 states that have allowed certified professional midwives, and they have dealt with these issues. There's limited liability for doctors who do the backup. There's a lower standard of negligence for those doctors. There are hospital backup procedures that are very strict. There's also very strict patient waivers so that patients have full disclosure and know when they do choose a home birth what they are getting into. I think today has revealed that there are a lot of issues around this topic and valid issues. And like we've said, home births are happening. So we can choose to ignore it and just let them continue to happen, or we can try to address it and be responsible. Thank you for your time.
Thank you, Representative Benefield. To the authors, Representative Benefield and Representative Thomas, before I ask what is the pleasure of the committee, I would like to know and take my privilege of being the chair and saying that should this pass, and before I ask for a vote, would you consider an amendment that one of the two lay people from both the House and Senate would have to be a practicing obstetrician? Okay, so what we would have would be what the committee's pleasure would be on the substitute to House Bill 1191 as amended.
And so what would that make the resolution?
Wait a minute, wrong one. Resolution, sorry.
So what would it mean?
Would be, this is my understanding, would be three members from the House, one obstetrician and one layperson, right? And the same from the Senate.
Could there be a midwife?
The layperson could be. But, would you like them?
I mean, I would just, if we're trying to get everyone included, I would think that midwife. Yeah, I would think.
All right.
I'd like to make that in form of a motion if it's appropriate.
All right, and then the motion that one member would also, of each of these committees, or these would be, each chamber would be a midwife. Any discussion? Representative Wilkerson?
I'm just, I want to make certain, is that one who is now licensed?
No.
Because I thought that's what, I want to make certain what the definition is.
You could put certified professional midwife.
Certified professional.
That's what I was going to suggest.
Okay.
Thank you.
Thank you.
Representative Thomas?
Let me just say what the situation is.
Can you turn your mic on?
Okay.
Go on.
Oh, it's all right. Okay,
soft.
My voice is soft. Wow. Let me just say this. In a way, then in that case, then I probably would like to ask if you add a little friendly amendment onto that. Then maybe we would make sure that one person be OBGYN, one person could be a certified midwife, but then I would have to ask then that we change it to be and add an additional member, and that additional member be a lay person. Because to be honest with you, there are some people who are doing of delivering births that are not at this point certified professional midwives, but they do have something to say in the discussion and probably would be of value. So I wouldn't mind if you just still at least let one lay person be in there who in their mind, according to the state's definition, is a midwife. But since we want, you know what I mean? Do y'all follow me? Yes. Okay. Thank you.
All right. Is that okay with you?
By all means.
Okay, well, I think you've heard there would be 6 people appointed from the House, 6 from the Senate, 3 would be legislators from each of the chambers. 1 would be an obstetrician, 1 would be a certified professional midwife, I think that's got, and 1 would be a lay person if this bill passes. Are there objections to that amendment being added? I hear no objections, that would be added. Now, what is the pleasure, and do I have any other, sorry.
I'd like to move for approval.
Do I have a second? Second. Discussion. Okay, all in favor of House Resolution 1341 as amended, approving and asking for a study committee, signify by raising your right hand. All in favor? Okay. All opposed? Okay. It passes, so House Resolution 1341, as amended, will be forwarded to the Rules Committee. Thank you very much. Okay. All right, let's see. Since I had it up and was looking at that and gotten a little bit confused, let's go with House Bill. No, let's do this one. Let's do this one. No. Let's do House Bill 873. This should be short and sweet. House Bill 873. Thank you, Representative Wilkerson. Okay.
Madam Chair, this is Chairman Lynn Walker's bill. I'm one of the co-signers. This is the one we were reviewing in our previous meeting, House Bill 873, and it's basically what we're doing is allowing physician's assistants to be used in a state of an emergency. We need, as you know, the PAs are allowed to practice under the supervising physician, and in the case of an emergency, which we clearly define, if a PA is needed and can be used, and that they would basically be allowed to work under another supervising physician during the emergency, and that would only be a 48-hour period max. It is totally within the guidelines established by the emergency plans by the Composite State Board of Medical Examiners. It's a common sense bill. It's one that unfortunately we may have to see implemented one day if in the case of a hurricane, tornado, plane crash, some terrorist attack or whatever. Be glad to answer any questions.
Any questions for Representative Wilkerson? Do you have questions?
Thank you, Madam Chair.
Okay. Does anyone from the audience would like to speak on the bill? No? All right, Representative Latimer. Okay, you had a question? Representative Wilkerson.
You might have mentioned this, but the determining factor, would that be if the governor declared a state of emergency, or what would actually trigger this?
Yeah, go ahead.
Right. Yes, if you'll go to the mic.
That's a very good question because it generated a lot of discussion and less language that we did work out with the Medical Association of Georgia. The issue that we're really trying to address is the availability of care before the governor declares that emergency. So that's why we have said it's created by conditions that characterize a state of emergency or public health emergency. But that's also why we limit it to 40. First of all, why we limit it to it's a request from the local emergency official or state emergency official. So it's not that folks just show up and start working. It's putting a plan in action, and then that would only be for 48 hours until the medical board can address the situation, which is what they did with Katrina. Then they sent out a notice that PAs could help if the or physicians faxed in this request. So.
Okay, who would be the authority?
The triggering authority would be would more than likely be the local official under the local emergency plan, unless it were
okay,
state
like your
level.
EMA director. Or?
Correct.
Okay.
Yeah, that's what's referenced in Title 338.
Okay, thank you.
Any other questions, Mr. Bauer or Representative Wilkerson?
Again, this has been very, very tightly drawn to protect just situations like that. But I was referencing a situation in the Navy. Was one of my best friends, a dentist, on board an aircraft carrier, and unfortunately there was a fire on board the carrier, and he was they had to use him as an anesthesiologist. I mean, it was one of those situations you really don't have time. You're trying to save lives, and that's what we're trying to do here.
Thank you. Representative Mitchell?
Appropriate, I'd like to make a due pass motion.
It is appropriate. Thank you. We have a due pass motion on the substitute to House Bill 873. Second. Thank you. Any discussion? Okay, everybody in favor, raise your right hand. Okay, anyone opposed? Thank you very much. The substitute to House Bill 873 passes. All right. Okay, let's do... next, House Bill 1191, Representative Benton. Come around.
Thank you, Madam Chairman, members of the committee. This is a continuation of last week's discussion on this. There were some questions raised, and the substitute that's in your folder is, we think, the solution to the questions that you had. What the original bill was found in Title 26, and what we did was we moved it to Title 16, which puts it in the dangerous drugs and controlled substance. Everyone who issues a prescription now, whether it's a doctor, veterinarian, nurse practitioner, they will have to follow this guideline of having their name printed below the signature. And I'll be glad to try to answer any questions.
And first, I'd like to thank the members of the committee that worked with Representative Benton to get this in the right area of the law. Thank you very much for doing that, Representative Carter and all. Are there questions for Representative Benton? Representative Kidd?
My only question is that you still maintain, and it's still true in here, that this can be printed by the doctor themselves in ink. It doesn't necessarily have to be a pre-printed form.
All it has to be is printed where their name
Legible.
can be read. Yes.
Is there anyone are there other questions from the committee? Is there anyone in the audience that would like to speak to this bill? All right, thank you. What's the pleasure of the committee? That. We have a due pass and a second. Is there any other discussion? Not? Oh, Representative Loudermilk.
Anyone here knows a doctor who prints legibly, I would I'd like to meet them.
I happen to live with one. Dr. Pepper does. I write like the doctor. Thank you, David. So, yes. You can tell we've been in session for a long day and it's getting late. Okay, everybody in favor of the substitute to House Bill 1191, raise your right hand. Anyone opposed? Okay, it does pass. Thank you very much,
Madam Chairman,
Representative
members of the
Benton.
committee. Thank you.
All right, let's see. Okay. Representative Carter, if you present House Bill 1008, please.
Thank you, Madam Chairperson, for allowing me to bring this back. As you know, this was brought before this committee once before, and unfortunately it was brought at a time when we were discussing another issue, and I felt like it got intertwined with that unfairly. So I hope that you will at this time be able to focus on this. It has to do with hospices, which I know many of you have had experiences with, and it has to do with palliative care. Palliative care is a relatively new term, relatively new philosophy that has come into vogue, if you will, in recent years. And it's really a collaborative or a team approach, if you will. It involves a number of people who provide a service. It involves, for instance, the physician in combination with a nurse, in combination with a chaplain, in combination with a volunteer, who all provide for different services. Not only do they provide for the physical and the psychological, but they also provide for the spiritual well-being, not only of the patient, but also of the family. And that's why it's so very important. Now, why is this necessary? It's necessary because hospices and hospice personnel are experts in palliative care. As the law is written now, as hospice is defined, hospice personnel can only practice when a patient has been diagnosed as being within 6 months of end of life. And simply what we're trying to do with this bill is to take that and extend it out so that hospice personnel, hospice doctors, hospice chaplains, hospice nurses, hospice volunteers can offer palliative care up to 2 years. Now, there was a concern among this committee at the last meeting that we needed a time definite, and that's what we've done with this amended version, is to bring about a time definite. Keep in mind now that this was brought up in the last meeting. Are benefits going to be extended? No. Benefits are not extended. Hospice benefits that are paid through Medicare, Medicaid, they will still be only applicable when the patient is within 6 months. But it would be a disservice if we did not allow these patients who have a life-threatening chronic disease to benefit from these services further out. This would improve the quality of life of these patients and of their families. All of us know of someone who has been diagnosed with a terminal illness, and we know how it can wreck a family, and we know what a drain it can be, not only on the patient, but also on the family. So what we're simply trying to do is to provide a service that hospice is an expert in, that these hospice personnel are an expert in, and allow them to improve the quality of care for these patients further out than what they are allowed now.
Okay. Questions for the author? Oh, Representative Kidd. Sorry.
Thank you for letting me ask this question. I haven't had much time to read it, so I'm just going to ask you.
Sure.
Where is it defined or spelled out who declares this diagnosis that's 2 years out? Who is the person that determines that time factor?
If you'll see on the first page on line 13, it defines advanced and progressive disease. And it means a serious life-threatening medical condition which is irreversible and which will continue indefinitely. And, of course, the doctor with a diagnosis defines that.
Representative Loudermilk.
Thank you, Mr. Chairman. Representative Carter, I got a couple of questions. First one on page 1, line 17, or that section. It references this, or on line 16, I'm sorry, this term does not include terminally ill patients as defined in paragraph 12 of this code section. What would be the terminally ill versus the advanced progressive disease?
If you look on page 2, line 31, it defines the terminally ill. And that is, of course, those who are within 6 months of life expectancy.
Okay, so this is just separating the long term.
Right.
The second question I have is on the second page, and I think we just answered that, being defining the advanced progressive disease. I appreciate what you're doing here. I've run into this myself, and I think that answered the question. Your first question answered both of mine. My father is on hospice care because of dementia from a stroke. He needs 24-hour care, but we've run into the situation where he comes from a tough family, and he just keeps hanging on. And we've run into this situation of continuing to get the hospice care that he needs, and I commend you for what you're doing. I fully support this.
Thank you.
I have a question, Representative Carter. Now, you're saying that the care, the payment for hospice wouldn't change, and that's for 6 months. Who will pick up the cost of these people seeing these patients?
Well, if they have private insurance, it may be billable through that, or it may be just the family decides to pay for it. But, one thing I might just want to add at this point, or interject at this point, is that we're not talking about any increase in scope of practice. We're not talking about any turf wars. We're talking about a disservice, if you will, to patients and to families who, because of the way the law is written now, the experts in this area are not allowed to provide that service.
Thank you. Any other questions for the author? What's the pleasure of the committee? Yes? Okay, we have a do pass. We have seconds. Is there any discussion? Okay, everybody in favor of the bill, raise your right hand. Anyone opposed? Do the same. Thank you. We have a pass to the substitute to House Bill 108.
Thank you, Madam Chair. And may I mention also that this is my favorite committee. Thank y'all very much.
Could I say, because I'm on, okay. Could I just say, Representative Carter, that this committee is very concerned about the patients of Georgia and making sure they get quality care. So I would like to thank the committee members for sticking with us, and for people who are watching us on the web, I would like to make a statement regarding the empty seats and people coming and going. We did have a late day in the session in the chamber. There are lots of other meetings going on because we're coming very close to the 30th day of the session, which is the last day that we can send bills to the Senate and that they can send bills to us. And so it always gets hectic at this time, and people come and go to other meetings. Thank you very much to all of my members. Y'all have been great all session about trying to make the meetings. Last on our list is House Bill 907. Representative Reese.
Thank you, Madam Chairwoman, and the Health and Human Services Committee. I would like to take a quick opportunity to introduce to you my fiance who is joining us today, Dr. Mandy Wilson, who is on faculty at Mercer. Mandy, if you'd stand just a moment.
Yeah.
So, thank
Welcome,
you for coming.
Mandy.
It was a surprise to me. So. Now the pressure's on.
Definitely marrying above himself.
Great. Thank you very much. I will
In
get
more
started with
ways
the
than
hour
one.
being late. Thank you for your time, and what I would like to do is actually introduce what we're going to talk about with a short news clip. And it's talking about a very growing problem, and that is what we have come to know as drug counterfeiting.
Just a minute, Representative Reese. Can the committee hold it together? And let's give him your full attention.
Representative Graves is helping me out with some visuals up on the front here, but that's understandable. Thank you, Representative Graves. Drug counterfeiting, and I think the best way to introduce it will be to roll the clip here. So, Clint, if you would assist me here.
Are the prescription drugs in your house safe? Well, according to a sobering new book out today, they may not be. Dangerous Doses is the culmination of a 3-year investigation by Catherine Eben. It examines the very real problem of counterfeit, diluted, recycled, and mishandled prescription medications. Melinda Murphy is here with exclusive details. Good morning, Melinda.
Good morning,
I think
Hannah.
when you go to the drugstore that what you get is safe. That's
Exactly.
the assumption that we all make.
Just like most people, I thought the same thing, that when you go to get your prescription from a pharmacy, you're getting medication you can count on. Medication that has gone straight from the manufacturer to the pharmacy and is safe to use. But as one Long Island family learned, that isn't necessarily the case.
I would wake up in the middle of the night screaming, crying in pain.
In 2002, Tim Fagan was 16 years old when he underwent a successful life-saving liver transplant. But something was wrong. Tim was having severe spasms, and nobody knew why.
It was extremely upsetting to see Tim in such pain, and we were totally helpless. I didn't know what to do. I didn't know where to turn. I didn't know who to go to.
Tim suffered for weeks, but only on the nights he was injected with Epigen, a drug designed to increase his depleted red blood cells.
It was traumatic enough to be giving these shots, but now to be giving these shots and knowing that he would have a reaction was just horrible.
And then Jeannie Fagan got a call from their pharmacy, CVS, that the Epigen could be counterfeit.
This is the United States of America, and I thought that our drug system was safe and secure. Lo and behold, Tim's exposed to counterfeits.
The only way to tell was by scrutinizing the label.
This is the counterfeit vial, and this is the actual vial. There's the only difference right up here. Counterfeit, real vial.
Holy cow. See the tiny degree symbol? It's missing from the counterfeit. Kevin called the pharmacy, the distributor, even the manufacturer. No one would explain what happened.
I was absolutely frantic as to what this counterfeit medication might have done to my son in the short term and in the long term.
As the Fagans searched for answers, medical journalist Catherine Eben began investigating counterfeit drugs.
What do you mean by counterfeit drugs? Counterfeit medicine means that what is in the bottle or in the pill is not what it says on the label.
So how does this happen?
Medicine moves through a complex distribution system where it is handled by many middlemen. And during that journey that our drugs take, often they are mishandled, they are stolen from warehouses, they are recycled and bought for cash from Medicaid patients, and they can also be counterfeit and deadly.
Why don't our drugs go straight from the manufacturer to the pharmacy?
So what they would rather do is unload all their drugs to a big distributor and have them deal with the logistics of reselling it.
Eben learned there are 3 large wholesale companies in the U.S. that handle 90% of our drugs. They purchase primarily from manufacturers, but they also buy from smaller wholesalers.
Then it is moved like a chess piece through this maze of distributors and wholesalers, and that maze is very poorly regulated. It's simply watched over by a patchwork of state laws with minimal federal regulation.
Eben's investigation led her to Florida, where she discovered there were nearly 500 licensed wholesalers in the state. Just about anybody could get a license. This opens the door for counterfeiters.
A number of former narcotics traffickers got state licenses to distribute pharmaceuticals. All they needed was a total of $900, a small refrigerator and some air conditioning and a lock on their door, and they were in business.
Nobody knows that better than a team of investigators in Florida, pulled together from 3 different agencies by former prosecutor Stephanie Feldman.
And I called them Operation Stone Cold because the people that we were after were stone cold killers. If you give a cancer patient hemophiliac-strength drugs, you're a killer.
And that happens?
That happens. It happens all the time.
Operation Stone Cold uncovered a trail of counterfeit drugs, including Tim Fagan's Epigen.
According to investigators, Tim's Epigen began as a much lower dosage, which would typically cost wholesalers about $260 a box. The original labels were washed off the vials of medicine and replaced with another label, made to look nearly identical to the label of a much higher dosage, which would cost $4,700 a box. The process is called up-labeling. So they were up-labeling right here in this trailer park?
Right here. Yes, right behind you.
Caesar Arias, a pharmacist and inspector for the state's Department of Health, was one of the investigators of Operation Stone Cold who tracked the Epigen.
Well, they traveled to strip clubs. They traveled through homes. They traveled in the trunks of cars without proper cooling.
And eventually, according to Eben's investigation, the Epigen was sold back to one of the original distributors, AmerisourceBergen, who sold it to CVS. In the end, 110,000 vials of Epigen and Procrit were relabeled, with a net profit to the counterfeiter of $46 million.
Why is our medicine not better looked after?
In 1988, a federal law was passed that would have solved that problem and required an audit trail for every drug that moved through the system. Lobbyists for the wholesalers came in and gutted that legislation. As a result, the federal government cannot tell you where your medicine has been, who has handled it, or what is in it.
The Fagans are suing both CVS and AmerisourceBergen. CVS declined a request for an interview and issued the following statement. After receiving an alert from the manufacturer, our pharmacist quickly alerted the Fagan family about the counterfeit medication. CVS has filed legal action against AmerisourceBergen and says it's taken steps to ensure its suppliers get medication only from reputable sources. AmerisourceBergen also sent a statement to CBS News. AmerisourceBergen is deeply concerned about the reckless activities of drug counterfeiters. As a result of greatly enhanced tracking, monitoring, and security controls since the period covered in Miss Eben's book, we have had no incidents of counterfeit drugs in our distribution centers. It's not enough for the Fagans. They hope new legislation will fill the gaps that now exist in the system.
You can't do this to people and get away with it. Someone has to be held accountable.
For Tim, the experience has been devastating.
I'm frightened every morning and every night now that I take a pill or a shot or whatever it is, because I'm not sure whether it's counterfeit or not.
50 people have been arrested so far as the result of the Florida investigation. Florida is one of 3 states that have tightened their pharmaceutical laws, and manufacturers and many wholesalers have also increased their security measures. In spite of this progress, the U.S. had 32 incidents of counterfeit medicine just last year, according to the Pharmaceutical Security Institute.
Really eye-opening stuff. Thank you.
Frightening.
Melinda Murphy, thanks.
I hope you found that informative. Since the time of this news report, roughly 10 other states have taken legislative action to address this problem of drug counterfeiting. Neighboring states like Tennessee are considering bills just like this one that we're presenting here today. These states are acting because federal law designed to crack down on this problem of drug counterfeiting has been delayed in implementation now for almost 20 years. The states have decided to address the problem themselves. House Bill 907 would be Georgia's effort to help address the counterfeiting problem. It does this by requiring a pedigree for all drugs that move into what is called the secondary wholesale chain. You have a handout there that kind of shows what we consider the normal distribution chain, and that is manufacturer to wholesaler to pharmacy to patient. We're going to talk just briefly about how the pedigree would differ through these 2 different methods of distribution. As the video noted, 90% of drugs are handled in what is called that normal distribution chain. That means they go directly from the manufacturer to a major wholesale distributor to the pharmacies that dispense the drug. The other 10% of drugs move through what's called the secondary wholesaler market. While only 3 companies distribute 90% of the drugs in the U.S., there are over 6,000 wholesalers in existence in the secondary wholesaler market that make up the other 10%. This market consists of typically small operations, sometimes run out of storefronts or homes. According to an FDA report last year, the vast majority of counterfeiting and other illegal drug activity occurs in this secondary market, leading the Wall Street Journal to call it the gray market of drug distribution. If the drugs move out of the secondary wholesale market, this will require the additional level of verification called our pedigree, which will be attached to the drug, showing every place the drug goes as it moves through the secondary wholesale system. Pedigrees have been called for in federal legislation, although never fully implemented. The FDA report on drug counterfeiting from last year again called for pedigrees, but the federal government continues to lag in enforcing the crucial step. That's why Georgia must act. The problem of counterfeiting is already present, and it's only growing. According to the World Health Organization, 10% of the drugs in the current world distribution system are probably counterfeit right now. The percentage is thought to be much less here in the U.S., but the New England Journal of Medicine said it still runs in the millions of tablets. Moreover, according to the World Health Organization, the counterfeit drug trade is expected to grow by 92% in just the next 4 years alone. House Bill 907 was introduced last year at the end of the session to allow maximum time for comment. The substitute you see before you is a compromise bill resulting from many conversations with those in Georgia who are committed to ensuring safe, legal delivery of drugs. I'm personally grateful for all those who contributed. Representative Graves, Representative Carter, Representative Parham, Representative Ron Stevens, and Representative Butch Miller all commented on this along with the Georgia Pharmacy Association. The provision of these bills are relatively straightforward. the legislation requires a pedigree for all drugs not distributed through the normal distribution chain. Under the bill, the State Board of Pharmacy will promulgate rules and regulations for the form of pedigree to be required. We have a sample of what the pedigree would look like included there in your handout as well. The bill also institutes strong penalties for those who violate the terms of this bill, which has been entitled the Prescription Medication Integrity Act. The core intent of this legislation is that any time a wholesaler is talking to a wholesaler about selling a drug in Georgia, both sides know that a pedigree listing every step of the drug's progress through the distribution system here in Georgia must be attached to that drug. While the legislation is not the cure-all for the problem of counterfeiting, it is an important step in an effort to ensure that the medications taken by Georgians are safe and that they are purported to be. With that, I'd like to introduce Melissa Bishop Murphy from Pfizer, who will introduce the head of the wholesaler relations for Pfizer. Together, they'll give us a few more details on the bill. And then I'll be glad to take any questions from the committee.
Thank you, Representative Reese. Good evening. We hope this won't take long. My name is Melissa Bishop Murphy. I'm the head of government relations for Pfizer. I have here with me today Craig Elstey, who is the head of trade relations for Pfizer. Craig will talk to you about what we've seen as far as counterfeit medications in regards to one particular product with Pfizer and what the results of those were. Craig?
Madam Chairwoman and members of the committee, thank you for your time. We're passionate about this. Product integrity is probably the most important thing to us, one of the major pharmaceutical companies. To give you a little overview of the issue, 3 years ago, fake Lipitor, Lipitor is a cholesterol-lowering drug, was sold in the United States, including the Georgia market, because of a faulty distribution system. The top 3 wholesalers, as they said earlier, account for about 90% of drug distribution in the U.S. Yet there are thousands of registered wholesalers in the U.S. creating a secondary market. When we look at this secondary marketplace, in light of the sharp rise in counterfeit cases in the U.S., it becomes increasingly clear that this large number of wholesalers requires increased regulatory oversight. This bill includes modifications over previous versions made by multiple groups over the last several years. Back to the Lipitor issue. How was it sold? Well, ultimately, federal prosecutors arrested a twice-convicted cocaine dealer who manufactured and distributed a convincing copy of the medicine. This was happening in Florida, unfortunately, and that led to legislation that was passed in Florida last year or the year before. The counterfeit product part of the product originated in Costa Rica. The product was repackaged by a repackaging company in Nebraska and distributed by secondary wholesalers in Missouri. This amounted to 200,000 bottles or 18 million tablets that had to ultimately be recalled. That's a 30-day supply for 600,000 people. The product was sourced in part of the product was sourced in Costa Rica. It was actually legitimate Pfizer manufactured product that was sent then to Brazil and then illegally imported into the United States into Florida. In Florida, it was commingled with counterfeit product. So you didn't know whether you had legitimate product or counterfeit product in the vials that were shipped. From there, it was sold in California, was moved from California to Maryland, from Maryland to Nebraska, where it was repackaged, sold to a wholesaler in Missouri, and then distributed throughout the country. And yes, some of that product did end up here in Georgia. In your packages, there are some pictures of counterfeit product. The top page is Viagra. The second page is Lipitor. Product on the left is indeed the counterfeit product in both cases. And if you look at it, it actually looks better than the legitimate product as it's stamped out. That's why it is so important to put an end to this as best we can, because you can't tell the difference. We spoke earlier about the normal distribution channel, which is manufacturer to wholesaler to pharmacy, ultimately then to patient. That stays the same. Nothing happens to that. No pedigrees are necessary in that instance. We mentioned the big three pharmaceutical distributors of AmerisourceBergen, Cardinal Health, and McKesson. They are, as we said earlier, they represent about 90% of total distribution in pharmaceuticals. But it's the medications that are sold through some of the smaller organizations with the multiplicity of distribution points. It poses challenges for regulators. And I think we mentioned earlier there's over 6,000 licensed drug wholesalers here in the United States. Pfizer, we deal with less than 40, so I can tell you the numbers that are out there. The whole idea behind this is to better ensure the safety and quality of pharmaceuticals. This legislation should be passed that increases the oversight of wholesalers, especially those operating outside the use of the normal distribution channel. We'd like to see strict relicensing requirements, with the Board of Pharmacy will be taking up, and then to create the pedigrees or legitimate trails for the sale and transfer of a drug that leaves the normal distribution. The Food and Drug Administration provides an annual update, and just recently they came back out with their ideas for combating counterfeit drugs. And it ultimately is a comprehensive report highlighting several measures that can be taken to better protect Americans from counterfeit drugs. I'll list them just briefly for you. One, securing the actual drug product and its packaging, which we, the manufacturers, do. Two, securing the movement of product as it travels through the U.S. distribution chain and normal distribution. That's what this legislation is all about. Three, enhancing regulatory oversight and enforcement. The Board of Pharmacy will be taking that up. Four, increasing the penalties for counterfeiters. That is in this bill. Five, highlighting or heightening the vigilance and awareness of counterfeit drugs. You saw the news clip earlier. And six, increasing the international collaboration as the FDA works with those folks. This legislation has been passed in 15 states to date. It is being considered in 22 other states. It has evolved over the last year and a half through the National Association of Boards of Pharmacy, input from the Healthcare Distribution Management Association and various pharmacy associations, along with the branded pharmaceutical manufacturers. And based on those changes, that's what you see there before you. We urge you, for the sake of pharmaceutical integrity, to support this bill. It's the right thing to do.
Questions for Mr. Elstey? Right, Representative Mitchell?
Madam Chair, I move that we do pass.
You're recognized for that right now. We still have someone else to testify. Do we have questions for the presenter? Representative Wilkerson.
Thank you very much, and I appreciate the hard work that's gone into this. I guess I'm coming from a standpoint, a legal standpoint. You said that this legislation, similar legislation, has been passed in 15 states. Noted that Florida is the first in 2003, so it's just a short time ago. But I'm just curious about any legal challenges that may have been brought by these wholesalers. I mean, they're putting some requirements on them that I totally agree with, by the way, but I'm curious if, indeed, there have been challenges.
To my knowledge, there has not been any challenges. There is a representative from the Healthcare Distribution Management Association who I think will be talking. He might be the one you want to address that to.
Thank you.
Any other questions? Mr. Mosby? Representative Mosby.
Yes. On the end. Yes. I got a loud mic, too. On the pedigree, can that be counterfeited as well?
Yes, they can.
Okay.
Paper pedigrees absolutely can. We're not speaking of just paper. We're talking of a pedigree, whether it's electronic or whether it's paper.
All right. So it's my understanding that when drugs are manufactured, they know how much has been manufactured and what's coming out of the warehouse. And so how that process, they maintain contact with those drugs. I guess from an inventory standpoint, what's the reconciliation process?
Well, if a manufacturer, or I should say if a wholesaler or a distributor sees a pedigree that has 3 or 4 different distributors on it, that's a pretty good tip that something's wrong.
Right.
Something's stinky, and it should be investigated.
Other questions from the committee? Thank you very much. I'd like to call Mr. Gonzalez.
Madam Chairman, as he's coming, I'd like to thank the committee for their time of hearing the bill and ask for favorable consideration of the bill. Thank you.
Proper time. Thank you very much, Representative Reese.
Thank you, Madam Chair and members of the committee. My name is David Gonzalez, and as mentioned before, I do represent the Healthcare Distribution Management Association. For the most part, I represent the 3 big companies that were mentioned earlier and 40 other members that operate in more regional places of the country. I know of 5 states where the bill has passed and have been in 25 states working this issue, and it is a complex issue. I'm in the envious position of being able to be here to oppose this bill for a couple of reasons, and I really want to talk to you about this because this is hugely important. My industry takes this as the paramount primary responsibility of keeping counterfeit and questionable drugs outside of the supply system. We're publicly traded companies. We're Fortune 25 companies that are doing everything we can to keep questionable product out of the supply channel. Here's the slippery slope that we go down with this legislation. Florida is a prime example of the proliferation of counterfeit drugs in this market. And I have to tell you, when I got here at 2 o'clock this afternoon, I was disappointed and shocked that the licensing components of this legislation were stripped out of the bill. There's not one more single important part of getting people that should not be in the distribution business out of the business than licensing, whether it be criminal background checks, surety bonds, a designated rep with accountability at each facility that we've seen in every state that's passed this bill. Quite frankly, it's the reason why Florida got in trouble. I urge you to look at the book on dangerous doses, which was presented earlier in the clip. I urge you to look at page 242, page 73, page 134, and page 244 to get an idea of the problems associated with giving criminals licenses and, coupled with this in every case, their ability to counterfeit a pedigree. The Epigen story that we heard today, the book goes into great detail about the ease at which a pedigree was produced in every single one of those transactions. Page 134 talks about the person whose job it was to get boxes of Epigen and create pedigrees for it. $100 a box was his pay to do that. What I'm saying today is that this is a complex issue. It's a 2-pronged approach. If you learn from Florida, and I urge you to talk to somebody from Florida on this because it's hugely important. But taking the Florida experience, if we don't get rid of the people that should not be in this market, we've done nothing because the pedigree system is the easiest component to getting into the counterfeit market. In fact, it legitimizes their criminal activity. And this is important because this is where Florida went wrong, is they had a false sense of security that because the pedigree document, which somebody referred to earlier in your packet, was something that said, hey, this product's good. We can rely on this product. Now, why has FDA not acted on this? And somebody mentioned that earlier, because that's important. Almost 20 years ago, as it was referred to earlier, FDA looked at this issue. And being in a position of determining whether or not a paper pedigree system, and it can be electronic, but what electronic pedigree means is you're able to send it electronically. It's like an email. It's an internet system-based system that at the end is a piece of paper. What the FDA has decided is because that's an ineffective system, we shouldn't implement it because it has shortfalls. The other thing about the FDA is as recently as 3 weeks ago, they had a 2-day panel with all the experts in the world on technology and said that until we can itemize, serialize one product from another with the exact same lot number, products that look exactly alike, same label, same lot number, until we can distinguish those 2 bottles from each other, and this is currently being looked at to be done through radio frequency identification. It's a code that every single bottle gets a different unique number from its previous bottle from the origin. And until we can distinguish those 2 bottles, and until that radio frequency emits the originality of that pill and where it's coming from and separate from each one, we've done nothing because counterfeiting pedigree is the easiest part to counterfeiting prescription drugs. With that said, we believe in a normal distribution system which is laid out in this bill. However, we live in a world where a cookie-cutter approach to what normal distribution is does not exist. We talked about a manufacturer to a wholesaler to a pharmacy. I could spend a lot of time here explaining a world in which manufacturers use an exclusive distributor who then sells to other distributors. A specialty distributor, whether it be because they deal with dentists or oncologists or other types of clinics or physicians, uses a different type of distribution market than the AmerisourceBergen, the Cardinal, the McKesson that you are more familiar with, the big three that do 90%. These are lawful businesses. They've been around forever. There's some pharmacists on this panel who can tell you that in spite of the big three that have been noticed today, there's a lot of good regional small wholesalers who do a good business and are serving some of their colleagues, if not themselves. And I'd like to talk about that if there's any questions, because I think that's also critically important. This is not an industry that should be left to just the big three, although I do represent them. I think it's something that it's an industry that should have proper oversight by the state, and I mean tough licensing standards. If you cannot produce the type of requirements that are necessary, and the licensing standards that I have seen in the 4 states that have passed this bill, and the other 20 states that are considering passing this bill and rules like this bill, then we shouldn't even be talking. The second part is that the state of Georgia knows specifically what they're getting with a pedigree system, and not to find out 3 years from now or 4 years from now that 20 cases of Epigen with 100 units in each case got through the system because somebody didn't look at the pedigree. I might also add that in the substitute that I've seen on page 4, lines 4 and 5, the bill specifically excludes manufacturers and pharmacists from having any part of this. So, and what I mean by that is authentication. If a pharmacy gets a case of a very important drug, there's no obligation. In fact, they're not required to do anything but keep it somewhere. And I'm not suggesting that a pharmacist has to bend over backwards to call every single person who is in this supposed chain of custody. But if they don't, they are the last stopgap measure between that medication and the patient who's going to get that medication. There's no responsibility on them to call anybody and say, is this a real pedigree or not? What good is the pedigree? As I've seen it in other states, and as it has been offered by the manufacturing community, this is an internal document that stays within the warehouse facility. No pharmacist ever looks at it. No pharmacist has to look at it. No pharmacist has to call to verify, or the word is authenticate, whether or not the chain of custody on that pedigree is real. What RFID gets you is the ability to do that, because the pharmacist has that vial. They can check it through the radio frequency that's coming out to see if it's authentic. It's a self-authenticating piece. A piece that's attached to each vial and unit of product they receive. And let me just close by saying there's one other limitation in electronic pedigree that you have to know about. And that is the pedigree system that exists or that allows the Board of Pharmacy to put together is similar to what was discussed in other states. And our problem with that is that it tracks down to the technology that we have today, and that is a lot number. As I understand it, and there's experts in the room that can confirm this, a particular product made by any manufacturer could have as many as 200 to 300,000 to 400,000 to 500,000 units with all the same lot number. Under a pedigree system that I know of today that has not yet been put in place in any state, because even that technology is not ready, but under that system, if a pharmacist were to check it, they would be checking against purchases from more than likely multiple distributors and against a lot number that would show up in transactions on as many different units as a product as that manufacturer is able to make. So my point is it's lot number specific, not unit specific. And that leads to problems down the road. And that's where we are with the electronic pedigree solution that has been talked about. Our goal is RFID. FDA's goal is RFID. I think Pfizer will tell you that their goal is RFID. In fact, they will also tell you that every single vial of Viagra coming from their distribution centers has an RFID tag on it. I don't know if they're doing that because pedigree doesn't work, but because it is what is the future. It is the way to distinguish bottles from their original manufacturer from those that are not. And And I think that we're seeing other players in the industry going in that same direction because it works. And I guess I'll leave it at that.
Are there questions for Mr. Gonzalez? Questions from the committee? Representative Graves, did you want to speak? Thank you. Thank you, Mr. Gonzalez.
Thank you, Madam Chair. Fellow members of the committee, my goal was not to speak today, and don't want to delay our hour of getting out. There's a lot of things to do. This is a very important subject. First of all, I'd like to thank Representative Reese and Pfizer for actually putting a lot of work into this bill and allowing many people in the industry, the board, pharmacists and all, to have some input this summer. I'm sorry. Everything that has been said today is correct. I don't think anybody has really given a lot of misleading information or any wrong information. The unfortunate thing for Mr. Gonzalez, I hate, is, as he said, this bill, as was stated earlier, this bill was introduced last year, a lot of work on it, and he got here at 2 o'clock today. And I don't hold you at fault for that. You may have had the input. I don't know about that, but all I want to say is everything that has been said is correct. This is a huge problem. Regarding the licensing function, we currently have in place today the Board of Pharmacy, Georgia Drugs and Narcotics, who licenses wholesalers, who licenses pharmacists, who licenses pharmacies. I can tell you, and Rick Allen is here from the Georgia Drugs and Narcotics Agency. This is being looked at and addressed to heighten the licensing issues. This is a national problem. We're putting in Pfizer and some of the drug companies are taking the lead on it because they've been hit. You know, their Lipitor got hit, and it was a big cost to that company. The federal government has not stepped up and taken the lead, so they're trying to get out and protect their industry. So I don't blame them for doing that, although I do feel like we're getting different types of legislation across the country. I also want to point out the secondary drug market, secondary wholesalers. I personally buy from one of those big three. I'm a large purchaser from McKesson Corporation. But I buy from some other places too. And their product is just as good. The integrity is there. But again, they're big secondary providers. One of the things we need to do, and I'm urging Drugs and Narcotics and the Board of Pharmacy, is to tighten down our licensing licensing functions to these other people. No, nobody in this room wants to sit around and have somebody who has a refrigerator, a lock on their door, and $900. That doesn't need to be the only thing where you get your drugs from. You expect more from that from the drug industry, and I can tell you the multi-billion-dollar manufacturing industry in no way stands by to do that. We used to laugh and joke years ago, some 21 years ago, when I was just become a pharmacist and even in pharmacy school, and generics were just getting rolling. And we used to laugh about, yeah, they made that in the bathtub down in Byron somewhere. Well, that may have been the case a long time ago. But secondary manufacturers and secondary wholesalers are a lot more in line with what you would expect. But there are those out there that are not. Is this bill going to fix that? No. Does Florida's bill fix that? No. Mr. Gonzalez talked about a different type of pedigree, electronic pedigree, who he knows how it'll work. But that technology's not ready yet. Well, thus, the different bill that we have here today, different from Florida, different from the other states, and different from every other state. There's not one standard bill that's going to be passed in any state today, because you've got 50 states that ultimately will deal with this product if the federal government doesn't step up and act. So I don't belittle anybody that has spoken, and if I offended Mr. Gonzalez, I don't mean to do that. I didn't mean that negatively. It's just the fact that, you know, no one bill is going to fix this problem. But I do encourage you to step forward and start the process by passing this bill. This will be an ongoing process. This is the first step in probably a multi-pronged approach that we're going to have to dealing with this issue. I may have been incorrect on the Epigen issue, but I thought on that thing it talked about it was relabeled product. Okay, so the gentleman that got the product, he still got Epigen. He got in a lower dose than he should have had, so therefore it was not the appropriate dose, so therefore it is just as wrong, it is just as deadly, it is just devastating as getting a different drug. So the problem in pharmaceuticals and the problem in distribution is so much more than this one committee can grasp, I promise you. I live it every day. That's what I do. And again, I applaud them for coming. I applaud Mr. Gonzalez and his group for being there. He represents good companies, same ones that these people sell to, that I buy from. And it's going to take a huge effort to fix this problem in our country. Criminals are always going to be there. We pass laws in this legislature every single day. And if laws fix the problem, we wouldn't be needed. There would be no need for a police force. There would be no need for jails because the laws would be there and therefore no one would break them. But I encourage you to understand the time and effort that has gone into this bill to try and meet the need. It is not perfect, I promise you. But it is a good first step for our state to at least begin addressing a problem, to get a great dialogue going between the manufacturers, the wholesalers, the Board of Pharmacy, Drugs and Narcotics, and us, the legislature, to at least move forward from here and hopefully build upon it. And maybe someday, the federal government will come down, and I'm going to never say they're the end-all answer, but this is a large problem. It is interesting. Pfizer is the only company that stepped up. Now, I'm sure they've worked in collaboration with other GlaxoSmith, Wellcome, Klein, Burroughs, whoever y'all all bought out. There used to be, trust me, there used to be about 50 major pharmaceutical companies, and now there's only about 6 because they've all bought each other up. That's why there's only 3 major wholesalers because they've all bought each other up. But there you go. But, I talked much longer than I intended to, and I didn't intend to when I first walked in the room today. I'll be very honest with you, and I think the people here know I don't necessarily like this bill. I don't like, all the parts of it, but I think I've been very clear in the fact that it is an effort, has to be addressed, and we're taking a step forward to at least start the dialogue, deal with the problem, and put a basic level of some sort of answer forward. And from this point forward, with that coalition I mentioned earlier, including Mr. Gonzalez and his group, hopefully we can address this problem in the best way for Georgia. And any questions, I'll be glad to answer them. But
any questions for Representative Graves? Representative Chuckas.
I appreciate everything you've said, and I agree with you that everyone was sincere in their statements. And I'm going to ask you to look into the future and tell me what you think we should be doing on the next step after this to ensure the safety of our citizens.
Well, ultimately, I think, and I agree with Mr. Gonzalez, ultimately we'll get to that electronic pedigree. You'll know where every pill is. But, I sit there and I think about what I do in my pharmacy every day. I know where I buy my product from. I know my product's good. The recall Lipitor, I had none. I'm not saying that I'm perfect. I'm saying I couldn't have gotten some. The Epigen got into the AmerisourceBergen, one of the top 3. They went to a CVS pharmacy, the largest pharmacy company, individual chain pharmacy in this country. It got there. So it happens. And I think with this kind of dialogue, we're going to get there. Tightening these regulations, tightening the licensing, which the board and Drugs and Narcotics is already looking into doing, heightening the awareness, having this pedigree. Is it perfect? No. No, it's not. There are a lot of unintended consequences. When this bill started, there was a lot different. And there were so many unintended consequences in there, we kind of decided to eliminate some of those and make this a good first step. And that's why I applaud the authors for at least working with all those concerns to make those happen. So I wish I had that crystal ball. If we did, we'd change it tomorrow. But technology is coming. And unfortunately, new technology oftentimes comes because of negative consequences. Because of these counterfeiters, because of people that are doing things illegally, technology is having to get one step ahead of them to fix that. Will it be the final answer? Probably not. But again, every step forward to ensure the safety and security of our drug distribution system to patients of Georgia and the United States has got to be our primary concern here. So, yeah, a little inconvenience, all right, maybe. But if you know you're getting the right drug, and that guy that took the Epigen didn't have to go through that, then I think an extra 5-10 minutes, a little more paperwork trail, something, that may be it may be worth it.
Any other questions for Representative Graves?
Thank you, Madam Chair, members of the committee.
Thank you, Representative. Mr. Gonzalez.
I just want to clear up one point, and that is that I've been in constant communication with the bill sponsor staff and the committee staff, not only in trying to anticipate when this hearing was going to be had over the last 4 weeks, I believe, delayed, providing a letter with our comments, which actually are workable on the normal distribution thing that we talked about. There are ways to bring in the types of entities that I talked about. And please, I think it is crucial that whoever the entities that struck the licensing provisions, I have no knowledge, I have no reason to believe that they're not as powerful to do the same thing with the State Board or the pharmacy. Hell, it may even been them who took the licensing standards out. So talk to somebody from Florida about the licensing component and read those pages in the book that I referred you to, because they are plainly, clearly an explanation of how the pedigree system that we are going to work, that we are working towards without electronic pedigree, without RFID, can get us in trouble. And that's all I have.
Thank you. Mr. Allen, would you like to come talk? Yes, sir. Who is it? Okay. Yeah.
Yes, ma'am.
I would just identify yourself and who you're with.
Rick Allen, Deputy Director of Georgia Drugs and Narcotics Agency.
I just wanted clarification again, not that I don't believe Representative Grace, because I certainly do, that your group is working on the licensure.
They are licensed. We have, Georgia was in the forefront in the entire country 20 years ago, before Representative Graves and Representative Carter were even pharmacists, I believe, to license wholesalers. I was part of a federal task force with the FBI and Justice Department 20 years ago. I spent 5 years undercover with the FBI buying counterfeit drugs. I was part of the task force that drafted the Prescription Drug Marketing Act with Congress 20 years ago. I testified 4 times before Congress. I was part of every committee NABP's had to draft model rules and regs and laws. So yes, ma'am, we're very aware of it. We keep our eye on it. And yes, ma'am, we're doing everything we can.
Are you like Representative Graves and feel like this is a good step forward?
It's a good step forward. It is. I was part of the task force between the FDA and the NABP been a year and a half now. When the FDA came forward and asked NABP to draft some rules that they would follow. And the outcome of that was this radio frequency technology. And we realized then, we were told, this technology is not available yet. But I'm very aware, just like Mr. Gonzalez said, there are counterfeit pedigrees out there. There's some of these secondary wholesalers in Georgia we've shut down. They tried to move up here from Florida. We kept them from coming up here. Yes, ma'am, we're very aware of it. We try to keep our finger on it, and we do what we can.
Thank you. Are there questions for Mr. Allen? Okay. Representative Chakas.
Can you tell me approximately how many licensed wholesalers there are in the state?
I want to say around inside the state, or that we license.
Licensed wholesalers?
We license in-state and out-of-state. In fact, we were the first state to do that.
Okay.
Florida followed our lead. There are probably 300 wholesalers inside the state of Georgia.
Okay.
We probably licensed another 500 outside the state that sell into Georgia. In fact, it is against state law to sell a drug to, say, Representative Graves or Carter if you're in Colorado and don't have a Georgia drug wholesale license.
Gotcha.
So around 800, give or take.
Thank you.
Thank you, Representative Kidd.
Thank you to everybody who's testified. I can testify to it being a complex matter for myself to even, get my mind around. And I appreciate Representative Graves' honesty and candidness, and all the speakers. And I guess my question would be, we're here to a point where we can either pass something and fix it, or that's what I want to. If I don't want to create a false sense of security among the public if we pass something, knowing that it's going to need to be fixed, or if we don't. The other concern would be if we pass it and we get too far down some road that it's really more trouble and maybe possibly more dangerous to have to back out and go in a different direction. So your personal opinion of should we go with something now, however imperfect, and try to improve it as we go along, or should we wait and try to find something a little better later?
That's a good question. Again, I stick with what Representative Gray said, that this is a good first step. Georgia has not moved forward before. I applaud Representative Reese for doing this. It's needed to have been done. And it's a very hard question. I don't know if I have an answer to that question, because this bill has its good points and it has some points that, we need to look at otherwise.
Do you see a place in this bill that would be more trouble backing out of and trying to fix than it possibly may help in the short term?
Well, this current draft, I just had about 15 minutes to look at myself, so I don't really know where this bill has come from to where it is now. Okay. And everybody's worked furiously to try to get something presentable to this committee. So
I appreciate everybody's help.
I'm sure every time we're going to sit down and look at it, that somebody somewhere is going to find something. So possibly move forward, but be open to the idea that there are going to be changes.
Thank you. Thank you, Mr. Allen. Would anybody else that's spoken before on the bill like to have anything to say? Representative Reese, do you have anything to sum it up? All right. I think that we are ready for a motion. Representative Carter. That's the.
I'd like to move for approval.
Okay. I have a motion that we. Second. Discussion. Everyone in favor of the substitute to House Bill 907, raise your right hand. Thank you. Everybody opposed? The substitute to House Bill 907 passes, and we'll move forward. Thank you. I do hope, Mr. Gonzalez, you will stay, and Mr. Allen, I'm sure y'all will stay involved in the process as this bill moves on to the rules and then on to, hopefully, the Senate. Thank you. Right. Representative Chokas, just a moment.
Madam, this is addressed to David. Would you consider, now that we've passed this bill, perhaps a resolution for a study committee to go further and to take additional action at a later date?
Well, yeah, of course. These people sitting on the front row right here, and the Board of Pharmacy and Drugs and Narcotics. It's going to happen. It's just not going to. This we don't pass. As I said, this is complex. We don't pass this bill and the problem solved. This is an ongoing effort, and I think, to be quite honest with you, I think you're going to see so much pressure put on the federal government because all the states are doing these things that they're going to have to step in and do something in conjunction with the Pharmaceutical Manufacturers Association.
The Board of Pharmacy is working on this, and we'll be having hearings on the licensing. So there's still much work yet to be done with the Board of Pharmacy.
Representative Lowe.
This is a question for the chair. Ma'am,
Let's hold it together just for a couple more minutes.
this is a question about this committee. Is it the chair's intention for this committee to convene on Tuesday? Is there plans for meeting on our committee, our designated committee days for this coming Tuesday?
No, we will be in session on Thursday, so we would hold our committee meeting on our usual day.
Okay, thank you.
Unless otherwise notified at this point, we will be meeting on next Thursday. Thank you very much, everybody. Thank you for your attention and for staying with us till the end. Thank you. We are adjourned.